Hi, my name is Hei Kit Chan. I'm a fourth-year PhD student studying biostatistics at UT Health School of Public Health. I also work at the Department of Emergency Medicine as a research assistant. Today, I would like to talk about contemporary estimates of sepsis hospitalizations at United States academic medical centers. Before I begin, I do not have any financial relationships to disclose, and I do not intend to discuss an unlabeled, unapproved, or investigative use of a commercial product or device. To begin with, sepsis is a life-threatening condition resulting in organ dysfunction during cases of infection. It is well defined in ICD-9 codes. However, it does not have any comprehensive description in ICD-10 codes. So our objective in this study is to apply ICD-10 codes in all three subtypes of sepsis, which are community-acquired sepsis, healthcare-associated sepsis, and hospital-acquired sepsis. The database we used for our study was 2016 Vision database. It is also called University Health System Consortium. Vision database is a nationwide hospitalized patient clinical database. It is also a member-driven healthcare performance improvement database. One feature of Vision is that it contains expected mortality of each participating hospital for benchmarking and analysis. For our study, we exclude subjects who were less than 18 years old, incarcerated, pregnant, admitted for a psychiatric condition, under care of a hospital organization, or transferred from an outside facility. We use three different types of methods to identify sepsis. The first one is sepsis-free method, developed by Singer et al. In 2016. It is also the third international consensus definitions for sepsis and septic shock. The second method is Martin method by Martin et al. In 2003. It is a method that is based on discharge records with a code for sepsis in the National Hospital Discharge Survey from 1979 to 2000. And the third method is the Angus method, developed by Angus et al. In 2001. This method requires both organ dysfunction and infection to identify a sepsis case. We defined three subtypes of sepsis in our study. The first one is hospital-acquired sepsis, which the documented infection is not present on admission. The second type is healthcare-associated sepsis, which the documented infection is present on admission, and the patient had to be admitted from an inpatient nursing facility or readmitted within 30 days or on hemodialysis prior to admission. And the third type is community-acquired sepsis. In this case, the documented infection is present on admission, but the patient does not have to meet the condition of the healthcare-associated sepsis. In our study, we use hospital mortality as outcome, and for other variables, we look into sepsis subtype, patient demographics like age, sex, and race, ICU stay, which is defined as staying in the ICU more than 1 day, ICU admission, ICU length of stay, and also the general length of stay. In terms of statistics model, we used mixed effect logistic model. In the model, hospital mortality is the outcome. The sepsis subtype is the main predictor. The model is adjusted for patient demographics, which is age, sex, and race. And it is also adjusted for Bayesian expected mortality for each hospital. Finally, the model is stratified by each hospital as a random effect. For our dataset, we start with almost 6 million hospitalizations in 2016. After the exclusion criteria, we end up with almost 4 million hospitalizations. Using sepsis-free, we identified almost 131,000 cases of sepsis, and Martin criteria identified about 327,000 cases of sepsis, and Angus criteria had about 540,000 cases. And these sepsis cases were further divided into their subtypes. In terms of patient demographics, across all sepsis identifying methods and subtypes, the mean age of sepsis patients were about 60s, and they were slightly more male than female, but they were almost 50-50. In terms of race, they were about 60% white, 20% black, and 3% Asian. And all these patient demographics were all consistent across sepsis identifying method and sepsis subtypes. This shows that the Bayesian database is actually quite robust. And as for sepsis characteristics, for community-acquired sepsis, it has the highest ICU admission rate, the highest ICU staying rate, and also the highest incident rate. As for hospital-acquired sepsis, it has the longest median ICU length of stay, also the longest median hospital length of stay, and also the highest hospital mortality rate, both unadjusted and adjusted. This table shows the number of what I mentioned in previous slides. However, there's also one interesting point to look at here. That is, community-acquired sepsis and hospital-acquired sepsis, they both have opposite characteristics to each other. So community-acquired sepsis has the highest incident rate, while hospital-acquired sepsis has the lowest incident rate. Hospital-acquired sepsis has the highest hospital mortality, while the community-acquired sepsis has the lowest hospital mortality. This is saying that the community-acquired sepsis is more common, but it's less life-threatening, while the hospital-acquired sepsis is less common, but it is actually more life-threatening. In conclusion, in the year 2016, the incident rate of community-acquired sepsis could go as high as 91.6 per 1,000 person year, while the hospital mortality rate of hospital-acquired sepsis could go as high as 33.2%. We also note that the sepsis incident rate and hospital mortality rate vary with identifying criteria and subtypes. So when we are studying the epidemiology of sepsis, we need to take the identifying definition and the subtype into consideration. Well, thank you very much for listening and have a good day.